Recording in progress.
Sejam todos muito bem-vindos, bem-vindas e bem-vindes.
You all welcome. My name is Anastasia Monteiro. I'm a student of the Master in the Nutis Institute. I'm going to be the Master of Ceremony in this event. I would like to thank all of your presence and ask you to choose interpretation. There is an icon that's a globe that says interpretation, and you choose the language of your preference and click to confirm. If you are from a cell phone, click on the 3 points on the right side, select interpretation, Portuguese, and confirm. We will have the same information in English.
I am a master's student in Science and Health Education at Nutis Institute, UFRJ, and today I will be the Master of Ceremony of this event. It is a pleasure to have you with us today, and I will explain how you can activate the interpretation tool at Zoom. Click at the globe interpretation icon at the bottom of the screen and then select the option English and confirm. If you are watching from your mobile phone, please press the 3 dots in the upper right corner, click at the option Interpretation, select English language and confirm. It's also important to mention this event has been recorded. E nesse momento, daremos início à última atividade do ciclo de oficinas políticas antirracistas.
We're going to start the last activity of the cycle of workshops of anti-racist practices and policy in higher education, a partnership between Grace UCLAN and Newt's Institute. We thank the presence of the public, the speakers, the support technical group, and translation. And is being streamed by the YouTube, and the links are in the chat already. So to start, to invite the creators of this project, the manager of member of the Department of Equality, Diversity and Inclusion, Sueli Lugero New Love, and the nutritionist and doctors doctorate in the Newts Institute. We invite also Professor Gershon Davis, that is a professor of cardiovascular medicine in the School of Medicine, consultant cardiologist at North Cumbria Integrated Care NHS, and co-director of Globe. And also invite Professor Alexandre, and he is doctor in sociology by the University of São Paulo, and he is professor and director of the Newt's Institute in Education in Sciences and Health. After the presentation by the speakers, we are going to open for questions. So now is with you. Welcome you all, Professor Gershon, Professor Alexandre, Sueli, Anastasia. We are starting now this last workshop in this cycle. We thought about the importance of having in this event that is concerned and discuss the anti-racist policies. Is important to localize us at this moment of the COVID, the inequalities in health. I think that both the Newt's Institute also has a perspective of work in the sciences, health sciences. So it's important to bring the pandemic as another point for our reflection, what our universities have done to face the pandemic and the racial inequalities, the health inequalities. And it's with a great joy that I invite Professor Dr. Gershon to do his initial presentation. Please pass the floor.
Uh, who's speaking first?
You, Professor. She passed the floor to you.
That's great.
Yeah.
I just didn't understand the translation there.
I didn't hear the translation. I didn't
To the
understand.
organizers for inviting me
Muito
to
obrigado
give
para
this
os
presentation today,
organizados.
and
Muito
to Suli and to my Brazilian colleagues for joining on this webinar. I'll start to share my screen. Okay, so I'm Gershon Davis. Just to give a little bit of sort of personal background, I'm at the University of Central Lancashire in cardiovascular medicine and a member of the co-director of the Global Race Centre for Equality, Grace UCLAN. I was actually born in the Southern Caribbean in Port of Spain, Trinidad and Tobago, just in the Southern Caribbean before coming to the UK for postgraduate education and in medicine. So my talk today is about the COVID-19 pandemic, health inequalities, and the role of universities. And I'm going to give a UK perspective on this topic. First of all, I think we need to understand that health inequalities was actually around and a problem prior to the COVID-19 pandemic. For instance, in the UK, we had in 2010 in the UK a famous review and report on health inequalities in England by Professor Sir Michael Marmot from one of the London universities. And that was a landmark study of health inequalities in England. And that was in 2010. So 2020 was 10 years later, and there was some progress, but there was beginning of evidence that was showing that the health inequalities was actually widening in England and life expectancy was stalling. So there were some warning signs in relation to health inequalities. And the 2010 report in the UK, in England, showed definitely that health inequality was indeed a problem. Subsequent to that, 8 years later, in 2018, we have this report from Public Health England, which talks about and has proposal and plans for understanding and reducing ethnic inequalities in health. So this was a much more focused discussion rather than looking at health inequalities in general, in terms of regional remoteness, geography, and other aspects. But this was to look at understanding and reducing ethnic inequalities in health. So again, this is 2 years before the pandemic. This was recognized as an important issue within England by the Public Health England. And in the executive summary, for instance, it mentions that without explicit consideration of ethnicity within health inequalities work, there's a risk of partial understanding of the factors leading to poor health outcomes. So this was 2 years before the pandemic. In addition to that, there was a further statement in terms of local action on health inequalities, understanding and reducing ethnic inequalities in health. And this statement is particularly relevant as it points directly at policy in England. And just to summarize, it talks about the need for action on ethnic inequality to be championed by our senior leaders, both at the local and national level, needs to be integrated into health inequalities policies. So ethnic inequality needs to be addressed and needs to be a central part and a central theme in health inequalities policies. unlike several other countries, notably the US, and there's acknowledgement here that ethnic inequality remains a marginalized issue within much public health, as well as wider social policy in England. So there's recognition of the need to specifically address this. Fast forward to 2020, and we have the COVID-19 pandemic, the SARS-CoV-2 pandemic, which has affected everyone, really. And in the UK, we have statistical data and data that shows that over 3 million people in the UK have been tested positive for COVID-19 by March 2021. Many more have had the disease without any kind of formal test. We have a huge number that have been admitted to hospital, 450,000, and a 30% in-hospital mortality. So very significant effects of the COVID-19 pandemic. But before we do that, and before we look at that any further, in the early days of the pandemic, we were told and were informed in general that a lot of the mortality is really related to age and underlying disease conditions. So underlying conditions was mentioned quite frequently as one of the causes for high mortality. But it later became clear as the pandemic evolved abroad and in the UK that there was a disproportionate impact in terms of the effect on ethnic minority population. And this slide just gives some idea of the disparities in the risk and outcomes of COVID-19. So mortality rates, UK mortality rates were higher, almost doubled among Black and Asian ethnic minority groups. And it's not that the mortality rate was higher, but there are also other aspects to that, in that ethnic minority groups were also at higher risk of acquiring or catching or getting SARS-CoV-2 infection. So this disproportionate effect on the BAME, Black, Asian, and minority ethnic population became apparent as the pandemic progressed. And this affected not just the general population, but was striking in the UK in the effect it had on ethnic minority healthcare staff, who were amongst the first to die in terms of ethnicity amongst healthcare staff. So a lot more work has gone in to try to work out and decide why are ethnic minority staff and community more likely to acquire or catch SARS-CoV-2 and also to have a higher mortality rate. And some of the stuff and topics and ideas that are being suggested and researched include the fact that there may be an increased occupational exposure to the virus itself, or it might be that the social determinants of health, in other words, intergenerational multi-occupancy households, may also contribute to the acquiring of the infection. Deprivation may play a part. And what it has shown is that there was an exacerbation of the existing inequalities as a result of the SARS-CoV-2 pandemic. So what was needed clearly was further research initiatives, generally in relation to SARS-CoV-2 and the COVID-19 pandemic, but also into its effect on the BAME population and better protection in general for BAME healthcare staff. Whilst we have the acute effects, so to speak, of the pandemic on the left hand of this slide, we also need to point out that the pandemic itself, even with high vaccination rates, as we have seen in the UK, we may decrease this sort of acute phase, but I hasten to add that we need to be on the measures and lookout for the effects of the long COVID, in other words, the post-COVID effects, and the so-called chronic effects of COVID, which are both medical or clinical in terms of disease, but also have far-reaching effects in terms of other aspects such as mental health. And we already now have evidence coming out of the UK, certainly, of a disproportionate effect as well of long COVID on the BAME ethnic population. So I'll talk a little bit further about the COVID, long COVID, in relation to it exacerbating the health inequalities, ethnic health inequalities. And then we'll talk a little bit about the role of universities in this COVID-19 pandemic. So with the onset of the COVID-19 pandemic, as we've mentioned, it has shown and focused and highlighted the ethnic health inequalities that exist. And this is a slide in which has become a topic which has become quite publicized recently. The racism is a pandemic. It's highlighting the association between racism and the COVID-19 pandemic, and the COVID-19 pandemic exacerbating these health inequalities that pre-existed the pandemic, but has been made much more evident. So how can universities affect, or what is the effect of COVID-19 in relation to universities? We'll talk about that shortly, but I just wanted to show a slide that states that what we can do in our analysis of trying to understand why ethnic minority population and healthcare staff are more adversely affected by the COVID-19 pandemic, we can look at that in terms of the different journey or course of the disease. In other words, we can look at it in terms of increased exposure to COVID, to SARS-CoV-2. The BAME population more likely to be exposed, and we talked about that in terms of the types of occupation that they do. Certainly in the UK, in terms of public-facing occupations, quite a lot of ethnic minority populations involved with that. We could look at it as is there a difference in susceptibility to infection? We could look at it in terms of criteria for vulnerability to the disease. In other words, stress, air quality, immunity, pollution, where BAME populations live. We could look at the differential effects of disease, social consequences. So at every aspect of this chain, from exposure to infection, to acquiring the disease, to severe disease and mortality, and social consequences, we can see how COVID-19 is impacting adversely on the BAME population. And we can look and determine how people in general, how governments in general, and how universities can make some impact on this. So again, this slide really talks a little bit about one of the aspects in relation to ethnic minority population and the so-called trajectory of health seeking and healthcare. So in other words, is there any aspect of this trajectory that makes the BAME population more likely to acquire and have adverse consequences in relation to COVID-19? So whether or not it's the effect of community, of relationships, of time to presentation to emergency departments, of the care and admission that they get at hospitals, different aspects of this can affect the BAME population in terms of acquisition and effects of COVID-19. So as we've said before, it's increased this health inequalities in relation to systems such as risky occupations, worse housing, lower finances, access to the vaccination programs, and even the lockdowns and the financial effect on the lockdowns. So here we have Health inequalities, as we've mentioned, being observed in the UK as an important point in 2010 in the Mahmoud report. We see in 2018, Public Health England focusing on ethnic health inequalities. And then we have the COVID-19 pandemic in 2020. So within that pandemic, we have governmental action and we have universities. And just to borrow a slide from Sue Lee's earlier presentation in terms of UK, we could see therefore that in the UK we have around 281 universities within the spread around the UK. So we'll look a little bit now as to how did the UK sector, UK university sector, deal with COVID-19. So we look at the impact of COVID-19 on the university sector directly in terms of the short-term impact on teaching, having students to move off campuses because of social distancing, etc. The move to digital technology and digital learning. And that's the sort of short-term impact on the university. But of course, there are more long-term challenges in dealing with this impact from a university and academic perspective. But I'd like to concentrate more specifically on the university's response to COVID-19. And it must be said, throughout the UK, there was a very huge response from majority, if not all of the universities in the university sector in relation to the acute pandemic as it spread from around February of 2020. And the sort of university response overall has been in relation to things such as research into COVID-19 itself, in terms of research into development of vaccines, which, as we know, has provided a lot of fruit and benefit, research into testing and helping with testing in the early days of trying to get widespread testing programs for COVID-19. Then there was the university's response in terms of resources and people power, and we'll talk about that a little bit shortly. There were universities' response in helping people get through the crisis itself, and that's by communities and public. And then there's the university response in terms of supporting students within the university sector. So I'll talk a little bit about each of these just to highlight a few of the important points. So as we all know about research into vaccines and testing, universities were involved in things like track and trace, developing apps to track symptoms, developing some of the rapid testing technologies, specifically for coronavirus, and development of the vaccine against COVID-19. So that was a big area in the early days. Certainly testing was the first main area, and then vaccine research. In terms of resources and people power, there was outpouring of efforts from universities to continue to manufacture personal protective equipment, so PPE, whether face shields or gloves or manufacturing hand sanitizers. All the universities really turned their efforts towards this, and even in terms of donations, such as disposable gloves, as mentioned here, to the London Ambulance Service, for instance, or making university facilities available for either research or even testing. So a lot of resources and people power. This was also about helping people get through the crisis. So putting on things like online courses for carers of people with dementia to sort of reduce isolation and the effect of social distancing, or having learning hubs to help the schools and families that were no longer in school because of social distancing. So helping people get through the crisis was another big role within the university sector. And then, of course, we talk about supporting students and staff. It is within this area, I must state, that there was general mechanisms in terms of supporting students and staff, but quite a few universities were more specific in trying to address the support given for BAME ethnic minority staff and students. And understandably, this should be so because as the pandemic evolved, we saw quite clearly, as I've mentioned, the fact that this was a high risk group, a group that's really adversely affected by the pandemic based on a background of social and ethnic health inequalities that has been widened and made more prominent by the COVID-19 pandemic. So in terms of supporting staff, there was the work of one of the associate professors from Coventry University, which is a university in the Midlands in the United Kingdom, in England, in the Midlands area. Dr. Gurnam Singh produced a document focusing on measures that could be put in place to support the BAME staff and student community. And quite a lot of the universities, for instance, Bristol University, adapted this information and support mechanisms and suggestions for their students and staff. So this was a key area in addressing the hard hit, so to speak, ethnic minority staff and communities in relation to the COVID-19 pandemic. So I just, again, as I've mentioned, we must not stop there. There's a lot more work to be done and contributions to be made in light of the ongoing pandemic itself, but also the post-pandemic long COVID, post-COVID syndrome. And again, just to show here that in terms of post-COVID illnesses, risks are higher in those younger than 70 and in the non-white individuals. So this will require a really focused attempt at dealing with this problem, which is the post-COVID effect in BAME populations. So how can the universities move forward in terms of COVID-19 acutely? We've seen an acute response, but how can it move forward in terms of the remaining pandemic, but also in the management of the long COVID, which in itself would be, if not a pandemic, of a sizable health consideration? So it must be by working together. So it will be working together with academia, that's the universities and the university body. NHS is the National Health Service in the UK and in England, and it's a service that's free at the point of contact. So it's a public health service, and this has been responsible for dealing and managing and treating patients with COVID-19. And we have to also work with the minority communities to try and get the adequate support to these groups in terms of acute COVID, reducing the infection rate, reducing the morbidity, increasing the vaccination rate, and managing the after effects in terms of long COVID. So just a couple of examples of what certain UCLAN personnel have done in terms of the acute COVID response. And from that perspective, I have one of our colleagues prior to joining UCLAN was involved in a project called Air4U with Dr. Peggy Malongo. And this was a project that was a helpline, a telephone helpline to help emotionally vulnerable people within the BAME population who were affected by the impact of the COVID-19 pandemic. So again, a practical response to supporting the ethnic minority population who were hardest hit by this pandemic. I myself was involved in the production of physician-based material and patient-based material to help the communities understand how to deal with acute problems within the pandemic and to address some of their ongoing concerns. So what we've seen that there have been well-defined health inequalities in England, dating back to in the report in 2010. We've seen that in 2020, 18, Public Health England acknowledging the need for work, support, leadership, and action in terms of ethnic health inequalities. We've seen the COVID-19 pandemic in 2020 exacerbating the ethnic health inequalities. We have seen the response of the general public, of governments, and the universities' response to the COVID-19 pandemic in terms of practical help, in terms of research, in terms of vaccination development. But as we said, we need more focused contributions and impact for the population also that's at highest risk and most significantly affected by the pandemic, which is the BAME population. So that occurred in having that in 2020, and now faced with a long COVID pandemic, so to speak, in the population and again in the BAME groups, we have to move forward. And back to Mahmoud, who you remember had the 2010 report on inequalities, health inequalities, comes the report in 2020 of Build Back Fairer. So in other words, from this pandemic, as that collaboration, as I've mentioned, between universities or academia, with the health service, the National Health Service, with communities, we need to build back and build back fairer. So the sector needs to be part of this rebuilding process that should have a fairer society, and one that has less of this ethnic health inequality that has been so clearly and blatantly exacerbated and brought to the fore by the COVID-19 pandemic. So what can universities do moving forward? Certainly they can continue to do research and activity addressing long COVID itself and addressing its effects, both physical effects and mental effects, and the effects in the BAME and ethnic minority communities. Universities can be involved in addressing the issues that resulted in this disproportionate effects of COVID-19 on ethnic minority communities. Public health report, as I've mentioned, identifies racism and discrimination as key contributors to infection risk, outcomes, and life chances. So these are areas moving forward for universities to get involved with and contribute to building back fairer, as stated in the Mahmoud report. In terms of the research into racism, universities such as ours at UCLan are looking at, have awarded PhD studentships to encourage more ethnic minority-based research. So this is something that we're doing certainly at UCLan. So I'd like to wrap up there and end the overall discussion there by certainly summarizing the points that I've mentioned. Certainly from a UK, England perspective, we've highlighted the fact that inequalities in health exist from 2010 report, major reports. We've highlighted the fact that ethnic health inequalities exist in reports of 2018 and the need and the call for action in that area. We've seen the effects of the 2020 pandemic in widening these, not just health inequalities, but ethnic health inequalities in 2020. We've seen a concerted effort by universities to deal with the pandemic for students, for staff, and also to contribute to the general population in any way they can by research, by vaccination, by testing, by donating resources. Specifically, we've seen highlighted the need for focusing on the high mortality and the fact that ethnic minority students, staff, healthcare workers are adversely affected by Gurnam Singh's report, and ways of addressing this in terms of protecting the BAME staff, risk assessing them in terms of frontline occupation and personal contact. We've seen the 2020 report, or Mahmoud report, of Building Back Fairer. How should we move forward from this? And then I have made suggestions as to how universities can contribute to building back fairer post-COVID. So I'd like to stop there. Thank you. So I'll stop sharing my screen now.
Muito obrigada, professor. Muito obrigada pela contribuição.
Thank you very much, Professor, for your contribution today. I think it's meaningful that we are talking about countries with different realities, background, policies, governments with different policies to face the pandemic. But at the same time, we have our health system in Brazil, SUS, in the UK, the NHS. And it's important to highlight that the existence of these systems have helped us face this pandemic. And at the same time, even having these different realities, but we see racism as a determinant in the dimension of health, and it's going to reach the oppressed people in a brutality way. And it's also important to highlight that having those systems, those health systems, at the same time, it is hard to advance within these health systems to recognize social policies beyond health perspective, but the policies directed to these oppressed population in terms of having the data and advancing in concrete agenda, and to advance each one of the elements that you've mentioned, Professor Davis, and as a way to have specific actions to ethnic minorities. And something that has called my attention in your presentation is the reflection post-COVID. Unfortunately, here in Brazil, we are far from this stage. Well, here is not easy the way we have dealt with the pandemic. I believe anywhere it has been an easy process, but unfortunately, we do have many challenges, especially in the way that we managed the pandemic, especially how the universities are going to play the role in a post-COVID-19 phase. And I leave here my question: what has been the position of the government and the policymakers in the pandemic management, and what are their position with respect to health policies towards specific ethnic minorities? So those are my questions to Professor Davis. And now I give the floor to Professor Fonseca. Good morning, good afternoon. It's a great pleasure to share this table with Professor Davis. I want to thank as well the media, Sueli, translators, and thank NUTS to offer this space of debate on Wednesday and today. I've enjoyed and appreciated the presentations. I commented with the meetings about the importance of this comparative perspective that brings many similarities, but also differences between Brazil and the UK, but it does help us to think about our position, about our certainties in a comparative way. to consider those different realities and contexts. So thank this for this opportunity. And I'm gonna talk in the same structure that Mr. Davis has presented, pandemic, universities, and post-COVID perspective. That's how I've organized my presentation that I'm gonna share with you now. So I speak from the NUTS, which is a sector of continuing studies in the University of Rio de Janeiro. And since February 2020, I'm the director of NUTS, and the pandemic topic is really present, especially in our center of UFRJ. I do remember our concerns with respect to the virus who started in China. And at the time, we had the advantage of the time. So in February 2020, I am a sociologist who works in the field of health. I'm not from the health field itself, but many colleagues of mine from the health field. And I remember in February 2020, we were writing a note in February 2020, and we were debating yet the matter of the travelers, and we're planning the beds in the hospitals, about the importance of lockdowns and isolation, and the need to increase the hospital beds. I do not remember if at that meeting we were talking about the production of alcohol and sanitizers, but I'm sure we talked about the hospital beds. And at that time, we thought that in the second semester in 2020, we would face greater problems. And for sure, the complexity of the management of the pandemic was great in many countries, most of the countries, but the levels were different compared to country, because countries had different resources, structures, and in Brazil, we had our health system, SUS, and we did have a immunization program, so we had a structured health system, a vaccination structure, and we needed two other central elements: leadership and cooperation between the different sectors of society. And we did not have here in Brazil, we did not have leadership nor cooperation in the regional, local, and federal levels. Unfortunately, what we had, as the newspaper Datafolha has published yesterday, we had a dishonest, indecisive, authoritarian, and stupid leadership managing this pandemic with more than 530,000 deaths in this context. So a terrible situation that encompasses the whole world, and unfortunately we had more problems that we usually face. And another matter that Professor Davis has mentioned, considering the social inequalities that are more blatant in a pandemic context, so we needed to have more effective actions. So with respect to the pandemic, comparing Brazil and the UK, today we are in this mark of 4 million of deaths, and England, the UK, also had some problems with respect to the management of the pandemic. In these figures, thinking the average death worldly and compared to each country, we could say that more people have died in Brazil than the average death compared to the world rate and in comparison to the UK. So we had more deaths compared to the average death in the world. So we have 5 times greater our rate compared to the average death rate, and while England is 3 times greater the average death compared to the world rate. And we had in two countries problems with respect to the management of the pandemic. And I remember a documentary currently that I've watched, a movie about China. It's impressive. The name of the documentary was 76 Days, but it's impressive how it shows the Chinese structure of its health system allowed, and of course, it is not expected to happen in other countries, but it's impressive. It was impressive. Their lockdown measures, the equipment they had and the work implemented within the hospitals, and a process that has been developed since the beginning of the pandemic, and obviously its impacts cannot be ignored. Even considering that numbers and figures are being underrepresented. And we also need to highlight that a political context could allow this to happen. But I wanted to highlight this robust response of China to this pandemic. Another movie that I've watched, a British movie called Together, which is a dialogue. It is a story of a couple with a child, a young child, and it's the beginning of the pandemic, and it tells the story until the beginning of 2021. And the movie talks about the misruling of the British government of the pandemic in the first peak of the pandemic in the UK last year. So the figures and the logic followed by the prime minister that has excused himself later on the way he had managed the pandemic, but somehow the country tried to solve these problems, and then there was a second wave fed by other variants, and then there was an improvement recently, and later on a recent increase of cases, and there is the hope that this does not reflect in the numbers of deaths. In 15 days ago, we saw some speeches about the Olympic Games, messages, and the hope to face it in a better way. In Brazil, on the other hand, we have the hope. I hope by the end of this year, a decrease of deaths, and hopefully the figures will come down in terms of the deaths in Brazil. Here on the second figures in the graphic, we see here the speed of vaccination. The United Kingdom is the blue line. They have more than 50% of their population vaccinated, and while in Brazil, 15% of our population that has been vaccinated. And we do need to focus on the funding of this vaccination. Another concept to think the inequality in the health system I believe in the context of pandemic is the excessive deaths. This sentence was organized by Oxfam. These figures, how excess deaths compare on the world since COVID-19 outbreaks began. And here we see how during the pandemic and the elements from racism and the enslavement's history of Brazil have an impact on the management of the pandemic. And I'm going to show some data that illustrate the situation. Firstly, the role of Brazil, one of the first countries in the world to be in the first rankings, the first position of this ranking of excess deaths. In one day, we had more people dying than the average rate of deaths in the world around April. That was the peak of the second wave of COVID-19. This is the relation to 1 million deaths. We are in the 13th place. In absolute figures, we are the third country in the world with 420,000 deaths in this period. So this is the figures about Brazilian data during the whole period of the pandemic. This area between the red line and the black line are the data of the excess deaths. And those are the figures by week. This is the same data from another perspective that are the contracting recruitment process. And again, we have this gap between the red line and the blue line. And it's interesting to highlight this emergency aid from the government that was a result of the parliament work that recognized the need to support people. And it's impressive how it impacted and assisted people who were afflicted by the pandemic so they could take care of themselves and their beloved ones and control the contagious spread of the virus. We have the data with the orange line. We still have a distance in comparison to 2020. Still about this professional data, here we have the figures of deaths, January 2020. This is by profession, drivers, janitors, security people, and the numbers of deaths we have here in January 2020 and January 2021. Those who have had more increase in death were people working in gas stations, then cashiers. In third place, truck drivers, 68% people working in gas stations, 62% truck drivers. And fourth place, security staff. And we must remember that some professions that need to be outside, to have contact with other people, we see more deaths in this group. We also see here the sector of restaurant, but most of the time they were closed following a lockdown. we see here an increase, an average increase of 13% below the increase of the deaths compared to the general population. So while restaurant had to close and stop their activities, especially with the increase of delivery food, we had an increase that was below the average rate. But on the other hand, we had an increase of other sectors that encompasses mainly Black and other minorities people. And then another data connected with the racial issue. Here we have a research of SEBRAP, and they identify the excess deaths between Blacks and mixed were in 27.8%, while amongst the white population were a little bit lower. And
Consequência desse processo é todo um aumento na questão racial. O segundo aspecto aqui que me interessa apresentar é em relação às desigualdades em saúde. E é impressionante a gente considerar o fato de que entre os trabalhadores, esses trabalhadores que morreram mais, que há uma presença maior de pessoas negras brasileiras, é o transporte público, por exemplo, essa foto com um impacto e uma representação extremamente significativa. De que forma a gente enfrenta um desafio e enfrenta um problema em relação à pandemia.
Professor, só um minuto. A gente está com um problema na tradução. A Gabi está falando no canal de português. Acabou de acontecer isso. Deixa a gente só resolver aqui para o professor Bessan poder te ouvir. Espera aí. Não, você está falando no canal de português. A gente está te ouvindo no português.
Aqui está aparecendo para mim em inglês. A mim em inglês. Eu estou no canal em inglês. Para mim está aparecendo em inglês. For me, I see English.
Vou tentar. Tamires, você me escuta, Tamires? Tamires, você me escuta?
Professor Wilson, just a minute, because we had a problem with the translation, so we are trying to fix, then you will return back to listen in the translation audio.
Can you hear me?
Hello.
Hey.
Well, I'm in the English channel. Can you hear me? If you can hear me, can you put thumbs up? Anyone? No? Anyone? I'm speaking English. I'm in the English channel.
I can
I'm
hear
in
you.
the English channel.
I can hear you on the
Yes.
yes.
You can hear me, yes?
Yes, I can hear you on the English channel.
So it's fine.
I don't have any translation on what I'm talking.
I believe it's okay.
Yeah, it's
Acho que
okay
tá
now.
okay.
Okay, it's back to normal now. Okay,
Okay, I'm here.
So,
let's
The
continue
English
now.
channel.
Okay. Okay, Professor.
Okay, so we can continue. You can continue, Professor Alexandre. So, with respect to the inequalities in the health system, and I think this picture summarizes very well our challenge. So this is a reality faced by the capitals in Brazil, facing a virus, COVID-19, in our society. So to think about these differences and inequalities and their impacts to health and the dissemination of COVID is central in any planning and action in health management. And we have a peculiar element that is highlighted by our government is that it's worried with economy. And what we have seen with our data is that federal government has not saved the economy nor health. And what we have seen with respect to corruption, erratic in all levels. That's what we have witnessed. Another similar element that we have is with respect to water access that has improved in last years, but we have the data that around 12-13% of our population does not have access to clean water in their homes, and it has a significant impact to children. So being the water as the central element of this pandemic management, the need to frequently wash our hands in a country that we see this inequality with respect to the access of water. When we think about northeast region, this is even a greater challenge that is directly related to health determinants in our country. And now I'd like to present some of the data. This data. Very briefly, with respect to the testing, the higher income, the higher were the percentage of testing of this population. So if we consider November 2020, so 30% of people with more than 4 SME could test if they had COVID or not. So whereas compared to poor people, they had less opportunities to check the presence of COVID or not. And with respect to race, these are the percentages of people who had access to tests and the relation to race. So we see the difference between blacks and whites with respect to access to information. This data is from EpiCovid, implemented by the University of Pelotas in partnership with the Health Ministry. For the person more the presence of COVID, those are 3 different phases in this research. So the poorer, the greater was the presence of COVID within the population. So among us, the 20% richer, we would find half of the presence of COVID in comparison to the poorest. This is the comparison with the indigenous population, where the presence of COVID was even greater in comparison to white people. And this was some data collected in the urban areas where the person would self-declare as indigenous persons. And the difference between, in comparison with white people, are really meaningful. And here we have data about how was the structurization of the pandemic in Brazil. We see a pandemic that happens in the urban and metropolitan areas, and more we see the change, especially with the second wave, that was the spread of the virus and the whole territory of the country. We see also this same pattern with the deaths, the same relationship between metropolitan and country cities. It also happens when we look at data with respect to Black and white population. It starts with high contamination of white people and low contamination of Black people, and with the time we see an inversion of this process, given that the hospitalizations in May last year increased a lot. And then last year, around April last year, we see the increase of deaths amongst Black population and the decrease amongst white population. Here we see the deaths of Black and white population. Dark blue is Black and light blue is white people. So we see excess deaths amongst Black population, while amongst white population we have a lower rate of deaths in comparison to the total population, white population in Brazil. So we see this discrepancy between Black population and white population. So more Black people have died during the pandemic in Brazil. This is some data from June. It shows the inequalities in Brazil. We have the hospitalization of Black people, Blacks and mixed. We see that the data of Black women and pregnant, the rate of deaths, we have 60%. So in Brazil, we have 17% more chances of a Black woman and pregnant to die of COVID than a non-Black woman. So this element, skin, is an important element in the analysis of these data. So before this framework and the racial inequality in the health group, I'd like to talk about the context of UFRJ. We have a group of volunteers that work with the vaccination. So they are coordinated by Professor Carla. And since the beginning of the pandemic, we have a building that was a building of classrooms, so became a center of testing for COVID. We have implemented thousands of tests in this building of our university. The university hospital of our university had some fundings from donations led by the team and the board of directors. By the way, these days we had the spread of some fake news that the funding came from Bolsonaro, but actually it was not true. We had an initiative that has collected 2 million reais, and we could install great number of beds in the University Hospital of the UFRJ. We also remodeled our hospital. We increased our electricity capacity. And in the beginning of 2020, those changes were implemented. We also have some changes in the classes. This is a live in our institute, all the engineering research and health research, clinical studies to evaluate the different remedies were studied. we have studied all of different medications, ivermectina, and other remedies. The matter of the production of alcohol, we received a strong funding. We started producing alcohol and sanitizers for the use of the university. We had a very interesting action that gathered the union, the professors union, the staff union, and the students representation group. And they created a forum thinking as well about the solidarity and the mutual support to the whole university community. Well, we have a diversity of challenges, but we had some responses to the pandemic in our university. Well, with respect to notes, we had a different variety of online meetings to discuss the pandemic. We talked about the statistics, the reality of pandemic in other realities of Latin America and African countries. Another topic, the topic of fake news, how it affects the pandemic and its management, and the idea of thinking this challenge and the pandemic impact on the education. So we do have this dimension within our institution to discuss and think the use of technology. Here is a specific work that was developed by Professor Isabel. This is the matter of social scientific issues within the pandemic. So some tools that support the educational practices. And this is a website that was thought for the basic education, as I've mentioned, about the remote teaching and research. So everything that encompasses, and something that I always say, online teaching is not just using Zoom. So it is a whole field that needs to be deepened. Well, and to wrap up, I mentioned these articles. The first one is related to the educational activities and continuing education that we have implemented with professors and health professionals. And a second article with a database that gathered with in an alliance that gathered a diversity of scholars, and we checked with data from worldwide, and we compared the data to think which countries had fake news and what kind of fake news they had. So we qualified them. And to finally wrap up, I wanted to comment two articles that were produced in Europe that illustrate our challenge and the role of university in this context. The first one is a study, very interesting one, that was led by Sweden researchers. They've analyzed in 2011, where WHO launched a campaign to reduce the event of cardiovascular diseases. So they've elected some activities that should be developed as a way to decrease and face these 6 risks to mortality, and as a consequence to decrease the deaths coming from these risks. And then a group of researchers used a data with 1,700,000 people, and they have shown that social inequality has more impact than obesity and hypertension. So the central point here and the argument is how come social, racial, and gender inequalities have been forgotten when we face non-transmissible diseases. So it is central to think social, gender, and racial inequalities. We do need to face these aspects. Should we think about health questions, of course, but we do need to discuss about social, gender, and racial aspects. For example, for an obese person, they are going to lose 6.5% of their lives, while a Black person is going to lose 2.5 years of their lives. So we need to focus not only on the physical activity or the use of metabolism, but this is the third risk that increases the possibility of deaths. But so we do need to consider the social dimensions. Another text that it was written by Michael Marmot, and the magazine that was where this article was published is this one, International Journal of Equity in Health, and it speaks exactly about equality, equity, and reality, and finally liberation. And then this text is a short text. It's just a comment from Marmot about health situation in Brazil and social determinants in health in Brazil. This article is from 2016 and the research was 2013, and he presents in the text that, well, we can think that Brazil, comparing to two situations, Norway, that would be like golden standard, and Paraguay, that is a Latin American country that is similar to Brazil in terms of reality, although it's pretty smaller. And he says that he is not going to compare Brazil to an African country that has worse data, but I'm going to compare with Paraguay, that is a closer country. So he shows that we have the pension in Brazil, 86% that is covered. We have less presence of maternal mortality, child mortality, and Paraguay with worse data and Norway with better data. And he says that inequality in Brazil is greater than in Paraguay. We've always learned that social inequality is considered mainly from health indicators. And Marmon indicates that we do need to study, understand, invest in the role of SUS, our health system, and think as well on compensatory and recompensation policies, such as affirmative actions, policies to face social inequality, racial, gender inequalities. So the role of these policies have impacted the Brazilian reality. So what we have today is that these need to be studied. And we need to look at what we have done that has created better results, even though we do continue having our inequalities. And to wrap up, I bring again that picture of equity, liberation, and I think that the central point today facing the pandemic with this misrolling government that does not develop robust measures to face this pandemic, it's the importance of the fourth moment. We must fight and struggle to take off the fence. We do need, as a university, to produce science, knowledge through teaching and continuing education, research, and to think about ways to take away the fences so we can reach the fourth stage of liberation, as our thinker Paulo Freire would say. Thank you very much.
Professor, muito obrigada, Alexandre.
Good afternoon. Thank you, Professor. I'm going to speak in English to give balance in the translation.
Explanation when you actually bring so many structural elements that justify the inequalities in Brazil. And then I was really struck by the elements of the experience, the frustration Brazil has faced in terms of leadership, cooperation, and the competence of the government, Bolsonaro's government. And then, as you finished talking about mentioning and quoting Paulo Freire, I think it's really important as well to bring that point about the complex of vira-lata, pedigree complex that Paulo Freire mentioned. And I think when you brought those very interesting analysis around the world situation, and you bring how Brazil, how each country is performing in terms of the fatalities and victims. Obviously, the population is the most victimized, and then obviously the poorest will be, and then the people of color will be the most penalized about this incompetence, and then we have similarly in the UK some elements of impunity about, as you mentioned on that graph, was a massive delay, a mistake that the government as well equally here did not show much competence or did not make any reliable decision, which could have saved so many lives as well. So in that point, Brazil, yes, is performing not very well, but we have mistakes and structural elements in the political scenario here that does not put the UK in a better position in that aspect. I really want to watch that film now, the Together. It'll be really good if you could share the link. And I think it's really interesting. I know we have a bit of, I want to leave time for the more discussion and questions from our participants. And I think it's really interesting really to bring to light what the Brazilian population is through the most, with the basic human rights, access to water. And also there was a narrative here quite concerning at the beginning, when we have the highest number of people in opposition. What happened in Brazil, we have since the beginning, the contamination by the COVID was mostly in the non-white population. So, and then in that sense, people start conjecturing, obviously based in ignorance, that could be something about a racial element on these individuals, but actually it was exposure. So it was pretty much going a narrative of eugenics, kind of very dangerous. And we have to challenge quite a few people in that sense, because obviously it was the exposure, as you mentioned, in Brazil wasn't different. And we have the number of deaths by people in these occupations who are more exposed in healthcare, in transport, in security. So that there is that similarity here with the UK. And obviously not having a proper management of the pandemic without a campaign with the negationist of the, being validated by the leader of the nation. Not having all that did cause a lot of people not taking the care and taking seriously the isolation, the wearing the APP as well. So, and then also we have a shortage here. Brazil had a shortage of oxygen in Amazon, and you have here the shortage of PPEs at the very beginning. Nurses wearing bean bags. So in that sense, it's interesting to put that analysis, Professor, that there is this, the grass always look greener outside. But I think this pandemic just leveled us up. South, global South, Europe, pretty much in the similar experiences of this pandemic. And I just want to, I like the positive element in these on the professionals, the health professionals, and then the power of the community and how the universities are investing and all these, despite the misinformation, the fake news. The universities in Brazil, and the UFRJ is done a fantastic job to bring all these events during this time, and then bringing to light, scientific-based information as you presented here. And I'm really, really impressed with the analysis you've just presented, and I've learned a lot from this presentation from you and from Professor Gershon as well, putting us in that scenario very, very well explained. Okay, I will not take more time on on my comments. I think we have questions here already. Is it only one English question, Tamiris? Yeah, I think so.
Sim, just as one. Thanks for your wonderful talk. Please, can you share your opinion how the university can get involved in challenging global inequality, especially with the vaccine now? Eu acho que é para os dois.
For both of you.
Yep, thanks very much for the question. The question really is about, how can universities get involved with the vaccine? I think certainly the universities have played a role in terms of development of the vaccine in sort of individual countries, etc. And some of that work was done in conjunction with, most of the work was done in conjunction with pharmaceutical companies. I think the problem seems, at least from my perspective, in terms of the global vaccination program, is about getting vaccines to some of the less developed or less affluent countries. And I just wonder whether, whilst a lot of that is in big, certainly pharmaceutical industries have a lot of control there, I just wonder whether universities have a role in terms of getting in technology and training out there so that different regions of the world can sort of produce stuff in relation to not just this, but in terms of future pandemics, getting the technology and training and this upskilling in terms of a regional basis. So maybe regional hubs, in these other parts of the world, sort of developing local technology and local staff with that. So I think that's more than likely, and of course the collaboration, this academic collaboration and technical collaboration in terms of building that sort of resource in those countries. And they said it doesn't need to be in every country, but maybe regional hubs where they can respond to things like this in terms of generating the treatment or what's required really to deal with these things. Thank you.
Só em relação à questão
Just in relationship to the issue of the vaccination, I think the challenge is the inequality in the vaccination I saw some data that among the richer countries, they're over average over 40% of people vaccinated, and in the poorest is an average 1%. So in a pandemic, this is a big concern, is very sad. The role of the universe in this process. In our case, we have a very severe problem aside of the need of the partnership, public partner, and the need of the speed that's necessary. We have problem with sources for the research. We have some problems that resources have been taken by the federal government, and so it's a major difficult to be able to work. So we are still not independent in our production of vaccines. I think that our Instituto Fiocruz is Instituto Fiocruz in Rio and Butantan in São Paulo. They are trying to be able to control an internal process of production of vaccine. And just as a comment as well, particularly based on what Sueli was talking, a point that was very important that a pandemic brought is that the importance of a consolidated democracy. The case of Trump, leaderships like Trump's that are, or leadership that are irresponsible and incompetent. These countries, in those countries with a consolidated democracy, they put those incompetent leadership in their place. And in Brazil, we could not do it. So this really marks the role of economic elite connected with the military groups with a fragile democracy. We have seen, like yesterday, the president talks against senators, he talks against WHO. So this goes beyond, the way that he plays, with our population. We have a problem with the division of the powers, where the judiciary is a power, the legislative is another power, and the executive is another power. It was important that our judiciary at one point said that it was a shared condition, the lockdown between the states and the president and the federal, because this is a federation of states. So is for the fact that today we have installed investigation committee in the abuse that happened during the pandemic. Is only thanks to this investigation committee that we have a real minister now that we didn't have throughout the pandemic, that we have an acceleration of the vaccines, that we have unfortunately, it took a year and a half for this legislative power to establish this investigation committee. So in other countries, because they have more consolidated democracy, 2 or 3 months later, even though their leaders were a problem, it happened faster. But in Brazil, it took this long time. One thing that I learned from this pandemic is the importance of a consolidated democratic organizations that fulfill, in fact, their constitutional roles, that they don't become spectators of the executive power, but that they assume their power that is independent as legislative or judiciary, and that this question involves the lives of the population. Thank you, Professor. The debate is very important. Was very important. We don't have questions, and our time we already is of what time? We can go with our final considerations, professors. We don't have anything else. And it's lunchtime here in Brazil, and people are hungry, probably. Thank you, professors. I'm going to, Professor Gershon could do his final considerations, and then Professor Alexandre, and then we'll do our own considerations and close with Anastasia.
Thank you. Thank you very much. And thanks to the participants as well for tuning in. I think it's a very important topic. And I think it's a topic that, as I said, has been really highlighted by COVID-19. And we can see similarities as well across between Global South and the UK in terms of, and I think in terms of certainly the sectors affected by it. And I think the graph that Prof. Alexandra showed in relation to the job and occupations of the people affected by COVID-19 and mortality could be reflected exactly in the UK. I mean, it was interesting to hear that, the sort of spread of false information in relation to whether or not it was ethnically related condition in Brazil. I hadn't heard of that before, but that would have been a very alarming miscarriage of information if that was allowed to spread. And it soon became quite clear that the issue was really one of occupational exposure and all the different socioeconomic factors leading to the high morbidity and mortality in ethnic population. And just finally, certainly in the UK, the issues were really about bus drivers, the wearing of masks. I think there was, just speaking from my personal opinion, there was a general feeling that it couldn't happen here or it couldn't happen here. And we had a lot of delay in terms of getting the right PPE or adjusting the criteria of PPE that's required, and a lot of delay in terms of accepting the wearing of masks. That took a lot of debate, before people wear masks. And everyone was sort of waiting on government to pass legislation before they implement anything. So there was certainly a lot of delay in PPE acquisition, PPE distribution, determining what is the required standard of PPE, as well as the delay in terms of wearing face masks. And the big positive thing that came out in terms of BAME and healthcare workers was the principle of finding out what the risk profile of the BAME staff were in terms of whether they had comorbidities, their age, etc., to determine where they should be working in terms of whether it be frontline exposure or whether they should stop having patient contact. But I suppose the other side of that was how well was that process managed. So thanks again, and thanks for the input and the viewpoint from Brazil.
Thank you, Professor. Thank you.
Agradecer
to thank Tamires and Sueli for this initiative, and Professor Gershon. Interesting, the data for this bank of fake news, false information. UK was the only country in October last year, one of the 10 largest one in the mortality rate. That was not one of the 10 majors in fake news, in false news. So UK did not have as much false news, fake news. I think that it had to do with the structuring of communications in your country that was less dominated by the market, with the strong presence of some of your press. I think that it was a data that called my attention. England was out of the curve of the fake news. It was curious. It was England and Peru. And then we found out that the data in Peru was underestimated. And so Peru had sub-notification. But I would like to thank the opportunity. I think one point from what Dr. Gershon talked, what the pandemic brought to us, the importance and the existence of these inequalities and how much damage they can do. And it's impossible to people who work in the health area to ignore social inequalities, racial inequalities, gender inequalities, and generational inequalities. This has to be in a very significant way in the work of the area of health. Okay, for us that we're going to lunch, a good lunch, and for those who are going to dinner, good dinner. Thank you, Professor. They were excellent words for close. I would like to say that it has been a great pleasure. Also because my origin, I am from Brazil, and I feel as many Brazilians who lost their families, who had so, so many losses, so much sadness brought by this pandemic, and the issue of democracy in Brazil and the conservative ideas here in the United Kingdom. So, in the spirit of being an activist, have my origin in the students' movement as a northeastern Brazilian person, an economic immigrant to UK, with this concern of bringing anti-racist practice and promote equality among peoples and nations, of being respected. We have to be respected for what we are, not by our characteristic or sexual orientation, to bring at this moment a spirit of unity, of solidarity that we feel now. And we don't want this conversation to end with this event. And may we continue this conversation. And now I'll do the maximum effort possible within my professional capacity to bring more partnership with Brazilian universities. I think a great step for this contact with the Federal University of Rio de Janeiro and Newton's Institute, and then with Grace, Professor Gershon is one of the directors. So we know where to get information also from the Global South, and to have this open door with the UFRJ. I'm so happy with the outcome of this event. Thank you. I also I also like Sueli. I thank all the people who have participated today. I think the last workshop is a tense discussion because we see this reality so difficult that COVID is exposing to all of us. But also we see how good it is to start to have proposals about some things. The pandemic exposes the space of the inequalities, but also the importance of the international cooperation, like for development of studies, like we saw in the development of vaccines, and also as alternative for this growth of negationism. Um, we cannot be closed within our walls because we are not going to get answers by ourselves, particularly in our situation that's a fragile democracy that has difficult to answer to this question. The more we are able to build partnerships, cooperation, maybe we can answer in a faster way to the demands of the reality. Maybe we can. It's very difficult to be Brazilian at this moment, but I hope we are able to get some kind of guarantee. The genocide is the real name of what's happening here in Brazil, that has to be seen outside and has to be brought to some kind of judgment outside, to some kind of accountability. It's necessary that the international community look at the genocide in Brazil. We are not able to get out of this situation without the support of the international community. I'm very happy, Sueli, that we were able to integrate our universities, and particularly the Grace and the Newts. We have so many common points. I think that we only can gain. We learn from the differences. Thank you very much. This is what I want to say. I was going to pass the floor to Anastasia to close the meeting. So we are closing. Unfortunately, we came to the and we thank the speakers, the mediators, to the technical team, to the participants, everybody who made possible this event. In behalf of the event organization, we want to thank the translators from GSN and IECO Translate.
Muito obrigada.
Aí, Gabriela e Paula.
Thank you, Gabriela and Paula. Thank you. We are going to thank the partnership with Minka Production, the Newtons Institutes, the technicians from UCLAN, Martin and Alex. I don't know if they are listening to us, and Wesley in the support here, and Grace that's supporting financially this event. And we are going to reinforce the request to do an evaluation of the event that we are going to send through email. This is very important for future, and you can follow us both at the social medias of UCLAN, UCLAN, and Newtons Institute. We see you in the next event. Thank you. Thank you, all of you. Have a good weekend, everyone. Good rest, everybody.